Kat.
Good morning, Qasim.
First and foremost, I have to thank our amazing founder and hostess with the mostest this morning for so graciously, her and her team, Celeste and the team, for putting this very important event together. And I'm honored that I could be uh, a presenter this morning. And I'm grateful that I went first because I'm the least qualified of our five panelists today. And you have some amazing, tremendous superstars coming behind me that I'm so happy to see. And I'm going to make sure I go back and watch the replays of all of them. And your keynote is the amazing scientist, Dr. Dawn Bussey or Buse. I still have to figure out, I got to ask her how to pronounce her name right.
Use.
But anyway, Buse, okay. And I've heard some people say Busey. So you say Buse, Kate? Cat?
Maybe I'm wrong.
Well, we'll find out later. Anyway, I'm looking forward to all those presentations. I again, as Kat mentioned, I represent a little small initiative known as Black Men Have Migraine Too. We're a couple of years in now in our existence, and I'm still a relatively I'm a newbie in this advocacy space, but I've lived with migraine all of my life. I'm just going to share a few words about my own story just by way of background. Then we're going to go to the discussion points that I have a few slides for. And note the slides are all taken from an existing study. So those slides are going to be in depth. The reference to the slides, though the references used for the slides will be available at the end of the presentation. And I'm going to lead with letting you know where I got the information from. So I don't want you looking for any big scientific, presentation. That'll come from Dr. Bruce later. In any event, my journey with migraine began, as far as I can remember, when I was 6 years old.
Wow.
I was in first grade and I started having these excruciating headaches. And my poor teachers and the teacher assistant, they used to try everything to help me. I would sit in the back of the class, and I would lie my head on the desk. They would go across the street to the restaurant there, and they would get me tea and toast because I was always nauseous with these headaches. It was a mess. So everybody, of course, is speculating. Oh, maybe he's straining, looking at the blackboard. He needs glasses. So we go for the first optometrist appointment. I go through the whole exam. Ma'am, your son has 20/20 vision. His eyes are fine. I keep having these headaches, but they're not as bad. They're not debilitating. I kind of push through them. Even as a little guy, I always thought I was kind of tough. So I'm pushing through these headaches, and then, like, later on that year, they're back again, bad in school. Take me back to the eye doctor. Go through the exam, same thing. 20/20 vision. Next year, I'm in second grade, midway through second grade year. Another incident at school. Finally, go to the doctor one last time. New year, final examination would tend to be final. It turned out to be final because the doctor told my mother explicitly, ma'am, do not bring him anymore for eye exams. There's nothing wrong with your son's vision. So we never got down to what the essence of the problem was. So now I go through life, middle school, high school, I'm still having headaches, but they're manageable now. They're not to the point where they're totally derailing me. But I'm sleeping a lot. I'm dealing with nausea and all these other things, and I'm attributing them at this point, folks, to maybe lifestyle because at this point I was an athlete by high school, and I was very involved athletically. The dehydration is always an issue when you're an athlete. So maybe I'm not drinking enough water. I have all these things that I'm doing to try to help deal with these headaches, but yet they're still there. I go to college, they get worse. I still attribute them to lifestyle, which is now exacerbated by the fact that I'm a DJ now. So now I'm late nights, strobe lights, party on, like it's 1999, and this is 1983 we're talking about. So finally, it wasn't until I was in my 30s and I had already stopped DJing and I wasn't as highly involved athletically as I used to be, except for playing maybe occasional 30 and over pickup ball. And I'm having these headaches again. My primary doctor at the time had experience with migraine, and he diagnosed me after a few minutes. He said, "You have migraine." So he starts me on the well-known. He starts me on beta blockers. So that's my first treatment out of the gate that works for a while, then it doesn't work. I go through the years. I'm somewhat better, but still living with migraine. Fast forward, they're getting crazy. 2003, I'm laying in the bed. Meanwhile, I never went to a neurologist after all this time. He never referred me to a neurologist. He's treating it at the primary level. 2003, I'm living in Philadelphia. I'm lying in the bed one night, and my foot starts to fall asleep, as we would say when we were kids. My foot's tingling. But strange thing, doesn't stop at my foot. It's going up my leg. Then I feel it going up my side. Then my left side of my face is numb. Then my whole right side is numb over the course of hours. And I'm freaking out. I'm downstairs with small children. My wife is away in Morocco on a summer trip with her school. So I'm like, wow, I can't get up in the middle of the night and go to the hospital and have my kids here. So by early in the morning, it has subsided a bit, but I could still feel that something happened to me. So I got the children together. My oldest son, he woke up. He was 13 at the time. I said, I keep an eye on your sisters and your brother. I'm going to make a run. I told him I'm going to go to the emergency room. Went to the emergency room, treated me, diagnosed. I didn't have stroke, didn't have any heart issue, things like this. So now they had me just IV for hydration. And the attending physician comes back in and he says to me, "He said, Mr. Nathari, I'm not a neurologist, but something you said when you were going over your history struck me. And I've heard my colleagues talk about a type of migraine that mimics stroke. So I'm going to refer you to our neurology clinic." 4 days later, I'm in a neurology clinic and they diagnosed me with hemiplegic migraine. So now is when it starts to get serious in terms of having to really deal with this. And by 2005, I was chronic for migraine and occasional hemiplegic migraine. So my struggle began, again, back at 6 years old. And it really was interesting to me that in 2005, when I started being treated by a neurologist full time, uh, the great Dr. Alexander Moskov, I got to mention his name. He told me, he said that, Qasim, the headaches you had as a child, those were migraine. He said, but you grew up in the 70s and the science hadn't caught up yet. Nobody was diagnosing children then with migraine. And remember, I'm growing up in Newark, New Jersey, particular urban community, mostly black people. Nobody at that point is even thinking about this 6 or 7 year old kid has migraine disease. All right. So I've been living now since 2005, chronic, although because of, being proactive and being able to be on a good managed migraine management system and the things that I do proactively, I'm much better than I was. But there were times that I literally thought that I wasn't going to make it. You know, one of those times, and this is lead us right into what I want to present in the slides. One of those times was back in 2020. By this point, I had relocated to Florida. I thought that maybe the weather there may help. That was one of the reasons I left. It wasn't the only reason, but I thought it would help. I didn't have to deal with the New Jersey winters and all those things like that. I thought Florida would be better. I'm lying in the bed after 3 days of migraine, nonstop. And I'm watching Good Morning America. And for the first time ever, I'm seeing a segment on migraine. Now, occasionally, in the back of my mind, I remember occasionally maybe seeing a commercial here or there about a migraine med or something like that, but I never really paid any real attention to it. But I'm watching this morning feature, and how amazing it was to me that the principal subject of this feature was a black woman. And it was the first time in any of my migraine life at that time that I had ever encountered anybody that looked like me. Even though she was a female, beautiful woman, she looked like me in terms of skin color, much better looking than me. So I'm watching this and I was just overwhelmed to the point that I actually went on Twitter, which was popular at the time, and I contacted Dr. Jen Ashton, who hosted the segment for ABC Good Morning America, and I contacted the woman and just told them how much this spot was helpful and how it really helped, to just bring awareness to something that I've never heard talked about on TV like that on any level. So at that point, we formed, communication, me and the woman, and that amazing woman I'm talking about is none other than the migraine diva, Jamie Saunders. So some of you that may have tuned in, you heard me tell this story before, but I can't begin any discussion about migraine, diagnosis, treatment, advocacy, or any of that without mentioning her and my gratitude to her because it was that encounter with her that morning, and then her the following year inviting me into this advocacy space for a DIHAC program. In fact, 5 years ago now, June 1st, 2020. He invited me. It may have been 2021. I'm a little foggy, but it was June 1st for the beginning of Migraine Headache and Awareness Month. That was my first entree into anything dealing with advocacy. And it was the first time that I actually felt like, as a black man, maybe my voice can matter. And there has to be other black men out there other than the ones that I heard about through my just being an athlete. I knew that Kareem Abdul-Jabbar lived with migraine. I knew that Dwayne Wade lived with migraine. I knew that the football player Terrell Davis lived with migraine and played during a migraine attack in the Super Bowl. I knew these things from my own research, but never had I seen anybody that looked like me come on and actually talk about these things. So for the past few years, I've been trying to be one voice to just raise awareness about this issue, particularly around the challenges facing diagnosis and treatment. And oftentimes when I introduce myself at panels, and Kat, you've been there, what is my standard introduction? Hi, I'm Qasim, and I'm one of 5 black men in America that live with migraine. And I say that facetiously, but not so facetiously, because if you looked at the advertising, the marketing, the overall outreach when it came to migraine awareness, you would think that black men didn't exist, or that black men didn't have migraine. And the fact that I'm also, I strive to be a man of faith and live with migraine, it makes me sort of a unicorn. Here's this black Muslim guy that lives with migraine. Let's, let's listen to him. So if I can use that voice in order to help, then I'm honored to be one of 5. But as we're going to see from these slides that we're going to go through real quick, there's more than 5 of us. And I'm really concerned that we're not doing enough to reach many that live with this reality. So with that, I'm going to attempt to share my screen. If I don't botch this up, bear with me. There we go. Okay. So now we have this reality about challenges facing black men in diagnosis and treatment. So let's just go to some of the numbers. All right, we have a quick overview. Okay, it says migraine and severe headache affect approximately 1.6 adults in the United States, and migraine is one of the most disabling disorders worldwide. Black or African American, and for the purpose of our discussion, I'm going to use black. For me, it's just it's more of an appropriate distinction, but of course, it's interchangeable with African American. So black men make up approximately 13% of the US population. So the study that I'm quoting from, they extrapolated the data from prevalence data, and they found that 4.3 to 7.2% of black men, which is the equivalent of 903,000 to 1.5 million men, black men in the US, may be affected by migraine. Now, as I said, again, I joke, one of 5, 1.5 million men possibly affected by it, yet I've never seen anybody that looks like me, in any, real role talking about it. And usually, whenever I'm on a panel of any type, other than our amazing brother, the great neurologist, Dr. Larry Charlton, affectionately known as LC, usually I'm the only black person in the room. Black man, that is. Let me specify that. I've met some amazing black woman advocates, as I mentioned, some amazing black women neurologists and headache specialists. So migraine is one of nearly 300 headache disorders, and disorder is spelled wrong, and the author of me is kicking myself, but I did this when I was in migraine brain fog. I'm going to beat myself up all day about that one typo. That's all I'm going to remember from this presentation. This is the OCD in me. So the true prevalence of migraine disorders in black men is not known. What we do know, however, is that the presence of racial disparities in healthcare are well documented, but not so much in headache medicine. Nevertheless, racial disparities in headache medicine exists. So let me just share with you an issue that I've had. as we go through these next points. And I'm going to stay on time so that I could be finished with to leave at least 15 minutes for questions. The headache disparities is one of the first categories that's mentioned in this study. And the study that I'm quoting from, I'm going to read the title of it because I think it's very important. Equity of African American Men in Headache in the United States, a perspective from African American headache medicine specialists. This is part one. This is the two part study, and in all my research, this is the only study or two studies that I could find that were led by Black neurologists or headache specialists. I couldn't find any others. And now, 5 years later, from the time that this first study was published, it was accepted for publication October 9th, 2020, going on 5 years. I still haven't found any other studies that's even addressing the issue. So I thank you, Dr. Charlton, Dr. Spears, and Dr. Flippin for collaborating and bringing this research to light. So one of the first things they talk about is headache disparities. And I'm not going to go into any real detail about it because I'm really trying to encourage all of you to read the study. I think that it'll inform a lot of our work collectively going forward if we read the study because the data in it is just glaring. So we know, or they noted that this particular study, it wasn't a comprehensive review on headache disparities regarding African American men, but it did note that nevertheless, race-based disparities in headache medicine exist in the United States. And then they give a couple of examples and they codify other, underserved groups that also are often overlooked in the diagnosis and treatment process. Very fascinating study, and I urge all of you again to go look at the data at the end on our last slide. We actually have the link to where you can find the study. The second point is a point that I feel that I want to really spend a few minutes on: mistrust. There has always been mistrust, or often there's been mistrust in terms of healthcare systems in relationship to the Black community. And these things are historically, just have been a major problem. And one of the major things that I could point to in terms of mistrust and how it really tainted generations of people, meaning African American or Black people, when it came to trusting uh, what do we call these things? I got a brain fog. Case studies and research studies and all these things was this experiment commonly known as the Tuskegee experiment, where Black men with syphilis were the people that were studied. They were the objects of this study. It's such a painful thing to relive, and we don't have the time to go into it. We could do a completely separate webinar just on that. But the outcome of that study and how those people were handled in that study is one of the major points that people, particularly people that may be conspiracy theorists within the Black community, when it comes to racial disparities, that's one of the first studies that they point to, how the Tuskegee experiment was handled. So you have this mistrust, and then you have the reality that we live in a country that, for all of the gains of the civil rights movement and all of the strides that have been made in terms of trying to establish better racial equality and parity and justice among the races, America still has a lot of work to do. And I think that regardless of anybody's political ideology, and I'm not here to have a conversation about politics, I think that if we're all going to be honest, we see that the country is now going back to a time that the civil rights era fought against ever being prevalent. So we have now an even increased mistrust because of the reality and the existence of systemic racism, and that certainly permeates throughout different levels of society. So we don't expect the medical field to be any different or to be exempt from it. The next point that they mentioned in the study, and I think this is also very important, is that Black men are understudied and there's a lack of representation in research. Already beginning by talking about how in 5 years I could only come across these two studies. Part one, where they laid out the numbers, and part two, where they laid out on the ground and institutional reforms that can help with the diagnosis and treatment of Black men with migraine. So there is so much data that's embedded in this, And I think that in the future, for us to really get our hands around what we can do in terms of dealing with this challenge of diagnosis and treatment or the lack thereof, we're going to have to admit that the research has really hasn't been represented. And again, that goes back to this whole mistrust thing. Myself, I've been involved in 3 different clinical trials in terms of migraine, but you're not going to get the average black person, particularly a black man, to be involved in any clinical trials, especially if there's medication involved. And again, in light of what we already mentioned, from a historical standpoint, it's just a slippery slope. So I think that a lot more needs to be done in terms of one, ensuring the integrity of these studies and making sure that there's a broader outreach so that we can deal with reducing this lack of representation. Cultural differences. And when we talk about cultural differences, we know that there may be cultural differences that play a role in one, a patient's adherence even to treatment once they're diagnosed, but more importantly, there's cultural differences in how people relate to dealing with pain. And one of the things that I want everyone to be clear about, and as a black man, I have no problem admitting this, because I've always been one to believe that once you get out of denial, then that's the first step to being able to eradicate or eliminate any crisis or any problem that we're facing. There is an unspoken taboo in the black community, particularly around black men, and there's a stigma around discussion of pain. And that also can be linked, not maybe not directly, but is definitely connected in some way, shape, or fashion to, again, institutional racism, because black men and black people endured so much, and the black man was always one to be looked at as this stereotypical, this strong black figure. This is where these stereotypical and societal tropes come from, mandingo and all these things, where the black man is looked at as being, a brute or a sexualized being, and all of that. That trickles down to even having conversations about pain. So as a young boy, particularly in the black community, if you're dealing with some pain or whatever, you most likely somebody's going to tell you, suck it up, just toughen up, you'll be all right. If you have a mother or aunt or a grandmother that advocates for you in that pain, somebody's going to tell her, oh, you babying the boy, he's going to grow up to be a sissy. And I'm using that language just in a cultural context. This is the kind of thing that would be said in the black community. So there was always this spoken and unspoken stigma about pain, around pain. So there's a major cultural difference that exists, and that is definitely a major impediment when it comes to black men seeking out diagnosis and treatment. And again, that probably contributed to my situation, because looking back on it, the pain that I dealt with in high school and college, it really should have been something that I shouldn't have dismissed, even with lifestyle. But because I was brought up in an overall environment where, hey, we're tough men, if you're a young boy, you're gonna grow up to be the man, you're the protector, you're the provider. Other people are supposed to tell you about their pain. You're not supposed to be in any pain. So it trickles down to what we find ourselves dealing with today. This next to last point is something that has become almost, it's almost been turned into a buzzword over the past few years. These microaggressions and macroaggressions, or as we categorize them, implicit and explicit biases. Most of you that are tuning in that took the time to log on to a program such as this, you already are well familiar with those things. You're acquainted with those things. I don't need to go into any of those things, but they're mentioned in this study. In fact, even the very term, this term microaggression, it was coined by a professor, Charles Pierce, in the 1970s, because he recognized, and I'm quoting from the study, these racial assaults to black dignity and black hope are incessant and cumulative. That's how he codified microaggressions. So now we see this played out on various levels of society, and we see that it's worked its way into the medical and healthcare field as well. And it certainly we find that the headache medicine field, isn't immune to such. So again, I urge you to go look at that part of the study. And the last part is this last point, this very, very interesting observation. The diversity tax, which they define as the potential peril for members of UIM, which is underrepresented in medicine. It's a very important term, underrepresented in medicine. Going back to what we're talking about, diagnosis and treatment, the challenges regarding black men. So black men in and of themselves are underrepresented, underrepresented in health in headache medicine. In fact, one of the things that they led with in this study, and when he talk about this diversity tax, again, refer to the study, it talks about how the toll is paid when black people become responsible for taking on challenges that affect their ethnic set or the ethnic group. And if you don't take on that responsibility, then it kind of becomes an out for other people to say, well, the black neurologist doesn't care about it, so why should we care about it? So he goes into detail in this study. They do. The three doctors go into detail in this study about how this diversity tax is a major impediment in the diagnosis and treatment of migraine and headache specialists. But I want to point out something that I found to be very disturbing, and it directly relates to this tax. They talk about the numbers of the organizations that exist today, and this is as of 2020. The study says recently membership of, and I'm not going to name the name of the organization because I don't want to offend anybody, but you read it for yourself in the study. Membership of such and such society has exceeded over 1,000 members. However, less than 0. less than 0.5% of its physician members are black men. 1,000, but less than 0.5, not 5%, less than 0.5%. I mean, it is an infinitesimally low amount of people. And then it ends, or I'm going to end what I have to say about it. As of the drafting of this manuscript, we are unaware of any African American male physicians in key leadership roles in any highly respected national headache medicine professional organization or society. Folks, that's a problem. That's a problem. That's a red flag. And I would think that if that applied to any other ethnic group, I think that there would be a national call to action to eradicate, that disparity. But this seems to be the norm. And I would venture to say that 5 years later, 2025, these same doctors will probably do another study and they probably would find that maybe very little, if anything, has really changed. So we can talk about the challenges and all of these things, but in the second part of the study, they talk about opportunities and solutions. And I didn't extract this from the study. These were things that I've actually come to terms with just over my 2 years in advocacy. And these are things that I've been having discussions with folks about. And these are spaces that I hope that Black men have migraine too can work in and hopefully take the lead in, and that others will support this work. And don't get me wrong, there are others that are already doing this work, but I think that if we amplify and we up the ante when it comes to marketing or identifying black men or African American men that can benefit from this, then it would inform our overall advocacy even more. So we see just from this study, and all of us as advocates, as patients, and all of us that are in this space, I think that we can all agree that institutional initiatives that they need to be taken to both increase the ranks of black men in headache medicine and increase membership within the major national headache societies. That has to be done. I think that, and that's something that I'm sure the black neurologists, the African American neurologists, are probably having conversations about now. And in these 5 years, again, well, not 5 years, 5 years since the study, but in my going on 3 years that I've been involved in advocacy, I've been on maybe 2 dozen different webinars at least and programs. And only 2 times I've been on with black neurologists. One, Dr. Charleston, and another, and my dear brother, his name escapes me, Dr. Williams, who's out of Los Angeles. He's from UCLA, I believe, and he's a consultant for the Lakers and a couple of other professional sport teams. Those are the only two times that I've been on. Dr. Williams was the first one that I was on for the DIAC program, and I know Jamie was responsible for making that happen. And of course, the LC, who I haven't been on any programs with, but I've been in a room with him, and I've been on in other advocacy settings in terms of ad boards and what have you. This second point, I'm very adamant about Black male centered advertising initiative, particularly on social media, television, and print and advertising marketing. I sit on an ad board for a pharmaceutical company that I'm not going to mention, and that is well respected, and I have great admiration for the work that they do. And I'm constantly talking in these sessions that we have whenever we have to review a commercial or an advertisement or anything. I see black women occasionally. I see who oftentimes I used to look at as the face of migraine, middle-aged white women, because for a time people thought that it was the middle-aged white woman disease and that black people didn't even have migraine. And most of the advertising that I still see today, other than the celebrity advertising, which they use, celebrity white women, which is fine if that's what you're marketing to, I don't see anything that's black male centered. So maybe there's a correlation that black men don't go and seek diagnosis and treatment because they don't see themselves in the advertising. So they dismiss their headaches as just high blood pressure or everything else, and they never get to the root source of what could be causing those headaches. So maybe at some point, and I'll volunteer. I don't mind being in some ads. I've been in some ads by default from the social media posts that I've made, and then they make those things into print ads. But I don't mind being in the TV commercial. I think I might be a little photogenic. I still have all my front teeth. I don't mind going. I don't mind going on camera and being in one of these commercials. So call me if you're interested in having a black man in a commercial. It would be great, and in all seriousness, it would be great if you could get one of the celebrity black men to be in these commercials. But unfortunately, and I don't know what it is, but I haven't found, other than a few situations, I haven't found any of the black male, the athletes, celebrity athletes, really talk much about their migraine publicly. I've only seen a few articles where they've been interviewed, but I think it would be amazing to get a high profile black athlete or entertainer or somebody to be in a commercial. And then don't forget the regular person like myself living on the ground. It would be great. Okay. All right. Okay. That was the pop up for the quiz. Good. All right. Get your questions ready. All right. We're going to go through these. Um, Cultural differences may contribute to headache care inequities. And of course, we understand that, and we already mentioned that. But this is something that, again, we need to really take stock in. Made me jump slides. So let me go back to where I was. We talked about the Black Male Centered Advertising Initiative, but this proactive, targeted initiative to reach Black men gathered in public spaces. I think this is the key and critical area. I've gone to many health fairs over the span of my life. I've been involved in a lot of community work. I ran a mosque. I have friends that are pastors of churches. I'm always attending community health fairs regularly. And never, ever, ever have I seen any information available at a health fair about migraine, ever. I see cancer, I see high blood pressure, I see nutrition, I see so many different things that are covered in the health and wellness space. I've never been to a health fair where I've seen anything about migraine, any information about migraine. So it got me to thinking that maybe we start to target black men in spaces where they gather, including but not limited to barbershops, fitness centers, sporting events, houses of worship, community health and wellness fairs, entertainment venues, fraternity events, things like that. So I'm currently having conversations with many of my friends and colleagues within the African American community that work in many spaces, and we're going to start targeting these type of events. The next thing, going back to having increased online presence, I've done a couple of these online series in a former iteration with one of the pharmaceutical companies that was involved in the migraine space that isn't involved anymore. They sold that component of the business. But Black Men Matter, migraine conversations. Let's start having more of these conversations on social media and podcasts, where we can bring on Black neurologists, Black headache specialists that can help facilitate these discussions. And we'll have discussions between doctors and patients just to raise awareness, and we can market these things within spaces where Black people gather on social media. And this last point is something that I've been adamant about, almost to the point that I'm excited and giddy about the possibility of making this happen. I've so often, I'm always tremendously happy when I see the push for mammogram and the mobile mammogram mobiles and things that go throughout the community. And I have so many women in my life and in my extended life that had this challenge of breast cancer and things of that nature. So I understand how important, early detection and treatment is in terms of mammogram. What if we took that same approach with migraine, where we had a mobile migraine wagon and we did assessment right in communities? You go into communities or you go into those spaces that I mentioned in the bullet point above, and you start having and you start doing assessment and you start having conversations and you diagnose people right then. You give them the Midas assessment, but then you also have a headache specialist there that can just talk to them and ask them questions. And I think that if you partner with your local hospitals and headache centers, you can probably multi-purpose some of the existing mobile equipment that exists already in terms of the vans, and just retrofit it with technology that's specific to headache treatment and diagnosis. And if you do this regionally and locally, then folks can gravitate on a regional level, meaning that if you're in a place like New Jersey, then you don't have to try to do one in all the cities, but you can do one in Essex County and then Central Jersey or places like that. And these things can be mirrored throughout the country. I think that these are just steps here. All these things that I mentioned, I think all of these are doable. I think these are definitely things that we can look at as low hanging fruit. It doesn't take a lot of effort. It just takes a real interest into wanting it to happen. As I heard one of our activists say, when it comes to many things in our community existence and our societal life, is often not a skill problem, it's usually a will problem. Do people have the will to take on the challenges of doing this particular aspect of the work? So I already started prematurely on these conclusions. Again, migraine and headache is common in Black men. There are potential challenges in the equity of Black men in headache medicine, cultural differences that exist. Black men, patients, and providers may experience microaggression and macroaggression as a result of implicit and explicit biases. The diversity tax is another challenge that may limit equity in those underrepresented in medicine. And lastly, the need for widespread institutional change and reform is evident. I think that we're at the point now where the data is clear, and we need to really be proactive and more aggressive in our approach about trying to reach that estimated 1.5 million Black men. And again, it's going to take a lot because of these factors that we mentioned, but I think that it would be a noble and praiseworthy endeavor if all those that are involved in the advocacy space, and particularly those from the various headache societies and within the pharmaceutical space in terms of advertising and marketing, that we begin to do more just to make Black men and Black communities aware that there is help out there, and there's a much different prospect for quality of life for the person that's diagnosed and treated than it is for the person that's undiagnosed. And I can't stress that enough. We know that there's no cure for migraine disease. We understand that. But the untreated person is just a person that just wanders around, and sometimes they can become almost hopeless. And what's always been said from a cultural standpoint about the Black community is often been said that if the regulars, if most of mainstream America catches a cold, the Black community catches pneumonia or the flu, meaning because of the factors that exist, everything is exacerbated and amplified when it comes to Black community. And the same thing definitely comes to Black men, who are usually more often than not, we're usually like the least thought about and the least paid attention to when it comes to these kind of spaces. And I can't even begin to tell you about the times over the years in my early treatments of hemiplegic migraine that I had to undergo some horrific experiences, because you go into the ER and you're dressed in your sweats and you're in the middle of a hemiplegic attack. They don't look at you as, okay, this is the Black man who's college educated. He ran communications for a mayor who's now a U.S. senator. They're not looking at any of that. They're looking at you coming in as a Black man in an area that is traditionally an urban center where they're used to people coming in the emergency room sometimes just seeking to be able to get medication, just to self-medicate. So you fall under that stereotype. And because of that, you'll sit in the ER like I did once in Philadelphia for 8 hours under fluorescent light before anybody would even see me. And then when they saw me after 8 hours and I gave them a protocol that I knew would help from my prior experience having IV treatment, they went and conferred, and 5 minutes later they came out and they gave me a little white cup with an Imitrex in it that I had a drawer full at home that I had just left and sat in your ER for 8 hours. So I say that to say there's a lot of work to be done, but we can't be undaunted by the challenge. We can't be daunted by the challenge. We can't be overwhelmed by the challenge, and we just have to face it. And we have the tools, we have the resources, and I think that collectively in our advocacy that we could do a lot to make a tremendous difference. And I thank all of those who've been involved in this space so far. I thank all of those who have encouraged me and have had conversations with me offline and shared things with me as I'm new in this space. And I hope to continue to learn from all of you. And we're going to start by learning from you and the questions that you ask me that are going to make me have to go back and think through some of the things that I know that I just spoke about. So I thank you for your time and attention. And again, thank you very much. It's been an honor.